Hello, and welcome to our second episode from IDWeek at the Boston Convention and Exhibition Center in Massachusetts, where infectious disease leaders from around the world are meeting to try and solve some of the world's toughest medical challenges. IDWeek is a joint annual meeting of the Infectious Diseases Society of America, the Society for Healthcare Epidemiology of America, the HIV Medicine Association, the Pediatric Infectious Diseases Society, and the Society of Infectious Diseases Pharmacists. I'm Katie Brace, and this is IDWeek TV. Today, we'll discuss issues around the use of antibiotics without a prescription. We'll try and decipher severe malaria with Dr. Chandy John, explore the ID Escape Room, and meet the finalists competing for the Idea Incubator Innovator of the Year Award. But first, 20 years ago, USAID launched the President's Emergency Plan for AIDS Relief. Since 2003, PEPFAR has helped over 50 countries curb their HIV epidemics. Joining me now is Dr. Michelle Cephedes. She is the professor of medicine at the Icahn School of Medicine at Mount Sinai. Thanks so much for joining us, Doctor.
Thank you for the invite.
Let's start with, why was PEPFAR set up initially?
So even though we think of HIV and AIDS as an epidemic, really some parts of the world are definitely more affected by it. So 90 to 95% of HIV was really affecting resource-poor countries. And essentially, the design of PEPFAR is to make sure that resources go to actually prevent, treat, and help really foster some of the economics and health of HIV was causing in these countries.
So you just touched on it a little bit, but can you go more into what the devastating impacts of HIV/AIDS are on not only here in the US, but other countries?
So in many countries around the world, about 50% of those infected with HIV are women, and women of childbearing age. And that's also the age that, people are the most productive, so contributing to the economy, right? So if you think about it, not only is it health and disease, but really also the economic impacts and the underlying infrastructures, but especially more of an impact in resource-poor settings.
You've been an expert in this field for about 20 years.
I've been doing this for a long time.
What are PEPFAR's greatest achievements to date?
So I think some of the greatest achievements of PEPFAR is really the marked reduction in the transmission of HIV from pregnant women to their unborn infants. So in the absence of actually having the medicines to treat HIV, it's expected about 15% of those children would be born positive. Now, with HIV testing during pregnancy, getting the mothers treated, undetectable, with such a low viral load that they won't pass it on to their children, the rates of transmission are less than 1% if a mother is diagnosed and treated during her pregnancy.
That's pretty amazing.
It's fantastic. It's really saved more than 5 million lives over these years.
So looking forward, when we're looking at PEPFAR's 5-year strategy, it's called Fulfilling America's Promise to End the HIV/AIDS Pandemic by 2030.
Correct.
How do we get there?
So it's really getting 95% of the people who actually are infected to know their status. So that means testing regularly. The most common reason for someone to transmit HIV to someone else is that they don't know their status. So the importance of testing cannot be understated. Access to prevention. There's actually ways to prevent HIV if you're actually still at high risk for obtaining it. And the last pillar is really kind of making sure those who are infected and know their status get undetectable so that they can't transmit.
Fascinating. Well, Dr. Michelle Cephedes, thank you so much for taking the time. We appreciate it.
No problem. Thank you again for the invite.
You can watch highlights from IDWeek TV on screens at the Boston Convention and Exhibition Center, in select hotels, on the IDWeek meeting website, and of course, find, share, subscribe, and like on social media. Next, the BEAT-HIV Delaney Collaboratory says the time is now for an HIV cure.
The BEAT-HIV Collaboratory provides that safe space to be able to share ideas and collaborate with scientists from different backgrounds.
Learning from each other and benefiting from each other's ideas and knowledge, that's what the BEAT Collaboratory is all about.
The BEAT has invited me into the kitchen. They incorporate the community. They ask our opinions.
You know why you're doing this. You see the outcomes of the experiments that you're doing and where those new therapeutics are being applied.
BEAT-HIV is part of a national program to advance the HIV cure agenda through the Martin Delaney Collaboratory networks.
We've engaged the HIV community very early on in the design and the implementation of the study.
HIV cure strategies are being tested. We're making progress to be able to provide tangible options for people living with HIV.
We want cure research done. I think it'll happen in my lifetime, and I'm looking forward to that.
Next, antibiotic-resistant bacteria are a danger to all of us because they can cause infections that are difficult to treat. One of the causes of increasing drug resistance is the use of antibiotics without a prescription. I'm joined now by Dr. Belinda Ostrowski from the Albert Einstein College of Medicine and CDC Field Medical Officer, and Dr. Lindsay Leitner from Baylor College of Medicine to dive deeper into this issue. Thanks so much for joining us.
Thank you. Thank you for having us.
So let's start with you, Dr. Ostrowski. How widespread is the use of antibiotics without a prescription, not only here in the United States, but also internationally?
You know, I think that's really a tough question because I don't think we actually really know, because there are not studies that are going to be throughout the entire United States. I will say that Dr. Leitner and her group put something out this year looking at 6 healthcare facilities in Texas, and I was pretty shocked to find out that it was more than 40% of the prescriptions or the antibiotics were without prescriptions.
Exactly. Depending on the community and the patient groups, it can be anywhere from 1 to 66%, which is what we see in the Hispanic and Latino communities. So it's pretty, I would say it's pretty prevalent, but of course really underreported. We don't have routine data collection on non-prescription antibiotic use.
And I'm assuming it can be devastating to be using antibiotics without a prescription.
Yeah, I would think so. For the individual patient, it could delay the proper diagnosis. They could get a side effect from the medication that they're taking, maybe have an allergic reaction or get a type of diarrhea that we see from overuse of antibiotics called C. difficile, or they could, if they take multiple courses, get antibiotic resistance. And in aggregate for the community, we really don't want a lot of extra antibiotics out there because, if you overuse it, we're going to lose it.
100%, yeah. And I think for the patients that I've interviewed, most of them really know a lot about resistance, but they don't necessarily know a lot about the risks and side effects to them and to their families. So that's something that is definitely, an area where we can try to intervene.
And Dr. Leitner, you touched on this. You've recently done the qualitative study on this, and you're going to speak about it. Can you give us a little bit more insight?
So we found that with our patients, which we had a variety of different racial and ethnic groups that we surveyed, and people are using antibiotics without a prescription pretty frequently. It's something that's happening, and the reasons why they're doing this from our qualitative work are really, there's 2 primary areas. One is that patients really believe that antibiotics are this cure-all. They're equivalent to like a Tylenol. So they don't really necessarily know that there's risks associated with taking antibiotics over and over. And also they've had previous positive experiences taking antibiotics and having their symptoms be alleviated. And then the second would be the healthcare system barriers. So a lot of it is because they can't get to the doctor, or they can't afford the doctor's visit, they can't afford the prescription medications or even the parking. What we're working on right now, my team and my colleagues at Baylor, we have a patient-provider communication tool that we've been developing, and we're piloting it right now. And basically it has a lot of really great education about the risks to the individuals, and we talk about resistance, of course, as well. We talk about appropriate antibiotic sources, which is only prescribed by your doctor for the condition. And then we also provide them with alternatives to some of the common symptoms that we keep seeing coming in over and over and over again. And I think we're on the right track. We just need to do a little bit, just a little bit more.
Dr. Ostrowski, as we talk about illnesses that are resistant to the antibiotics, are there any antibiotics in the works that are going to push us up to the new edge where, okay, an infection is resistant, but we have something to combat it now?
I think that, there are antibiotics in development, but it takes many years for antibiotics to come out, and often they are for some of the more significant resistant issues. I think what we're talking about, even if there would be new antibiotics, the thing is that we don't want to continue to overuse them. So I think we really need both of these parallel things happening at the same time. So it's really inspiring. You're not just measuring that people might be inappropriately taking antibiotics, but you're finding real life ways to try to combat that. Because even if I were to come out with multiple different new antibiotics, we're just going to lose them if we don't have the judicious use and addressing right at the source where the misconceptions might be, for the patients really to understand that they shouldn't take them without a prescription. And honestly, for most respiratory illnesses, an antibiotic isn't really even needed because they're viral.
Well, thank you both very much for taking the time. We appreciate it.
Thank you.
Next, join me as we take a closer look at how the University of Kentucky Division of Infectious Diseases Research bridges the gap between basic science research and clinical applications in the treatment of infectious diseases.
At the Bluegrass Care Clinic and in the Infectious Disease Division, we are driven by the goal of excellent patient care. We always want to wake up each day and remember, we are here for the patient. I think we've had a very successful trajectory over the years. We went from funding of $500,000 to a 16-fold increase. Our patient population of people with HIV has increased about 4.5-fold. We have achieved viral suppression in 93% of our patients, and our retention is 97% for patients with HIV.
The service has benefited me by changing my life. They sit and talk to me like I'm a human being. They have so much love and compassion. They've really helped me through all this and helped me grow.
We're now joined by Dr. Chandi John from Indiana University School of Medicine to talk to us about severe malaria. Thank you so much for being here.
Thank you.
So, should we be concerned about severe malaria?
Yeah, we should, very much so. There's more than 600,000 deaths from severe malaria every year, so it's one of the leading killers of children in the world. And there's more drug resistance and more insecticide resistance, so there's a danger that those numbers are going to go up. On the plus side, there's a new vaccine, so maybe that will help numbers come down, but it's still a huge health concern for children.
And you mentioned death being obviously a horrible outcome. What are some of the other outcomes?
So one of the things we study is neurodevelopmental outcomes in children. So of the children that survive, how does their thinking process, their behavior, their mental health, etc., develop over the following years? And we found that cognition and mental health and behavior are all affected in children with severe malaria, particularly a form known as cerebral malaria, which is kids with coma and severe malaria, and another form called severe malarial anemia, which is just what it sounds like, bad anemia with severe malaria.
And are these lifelong challenges that these patients will have to overcome?
We just completed a study. We had done 3 different studies looking at sequelae up to as long as 2 years after malaria. But what we did in this new study was get all the kids from all those previous studies, and it's now anywhere from 5 to 20 years after they had the episode, so some of them are adults, and we're looking at what happens in the very long term. We suspect it's a very long-term problem, but this study is going to answer that for us.
And obviously you focus a lot of your time on research, but I also have this fun fact that you write poetry and short stories. So how does this fit into all of this research and time that you spend on severe malaria?
Yeah, good question. Most of my poetry and fiction and essays don't have to do with malaria. They're just about different things. But I have written some poems about malaria, and I've written some things, both essays and poetry, about the children, the ones who are affected, and their families, and the bigger concerns. I think that poetry and medicine are in many ways two separate disciplines, but what poetry can get at is these bigger picture questions and kind of the heart and soul of why you do what you do and how life is affected, not just the particular health outcome you're looking at. And that's where I like to branch off into poetry and fiction.
Well, Dr. Chandy John, thank you so much for taking the time and talking with us.
Thank you. This was fun.
Now, more from the Infectious Diseases Divisions at Indiana University and how they are combining comprehensive care with intensive research and expansive training. IU's work on reproductive health aims to bridge the gap between lab findings and clinical research, alongside its research into malaria immunity and HIV.
Our mission is to improve the health of our local and global communities, to prevent disease, and to cure disease through research and education. We have multiple major referral hospitals, so we're a very large footprint in providing care in the local community, serving over 1 million people.
We're creating new knowledge that's informing policy and helping us improve on the care that we're providing for people. We're training the next generation of the workforce, of physicians, particularly those who are going into infectious disease careers.
We're looking to develop both our clinical workforce, our research investigators, our educators in adult and pediatric infectious diseases so that we can expand our reach as well as grow not just in our traditional areas of research, but also expand into new areas.
Have you ever been to an escape room? I have, but truthfully did not escape successfully. One of the newest events attendees can participate in at IDWeek are the ID escape rooms, immersive experiences to make learning about infectious diseases exciting.
ID is amazing. It has been stressful. I think it's time to have some fun. And so the idea here is team building in a relaxed environment. There's a little bit of education, there's some learning, but also just to have fun with friends.
Our group had an amazing time. We had a group of 7 that came in, a mix of pharmacists, ID physicians, so our whole team came together, and it was challenging, but not overly challenging, and extremely fun. And it was a great mix of science, puzzles, and just team building.
It was super fun. You know, it was a great time to spend time with colleagues. You got to kind of dig into some mystery, dig into a little bit of drama, and it was a great time.
It seems like it's been a big hit so far. You know, this is our first actual true run. We had a couple test runs yesterday, but we filled up our sign up within 15 minutes yesterday. Today our sign up's already full, so I think there's a lot of enthusiasm for this.
One of the things we hope is that people will see that teaching can be gamified, that learning can be fun, and that we'll have people take this concept back to their own home institutions and pay it forward. More escape rooms, more games, and more fun learning ID.
I think it's that education and focus on the field of ID that makes it really interesting. I know most of us are here because we love ID so much, and so getting to apply that to a fun situation like an escape room was definitely a lot of fun. It has that lead up to that question implied.
They did a really nice job combining a lot of different puzzles. So some puzzles that were microbiology based, some puzzles that were physically based, and you had to really investigate different things in the room. There was just a lot of different types of puzzles that blended together really nice to solve the ultimate prize.
This one does a better job of blending education with entertainment. I feel like at most of the other escape rooms, they're trying to balance a story that might be like a horror story or a comedy or something. This is very, science-focused, infectious disease-focused, but they tie it with fun. I think people will be really impressed by what they see when they get in there.
I think one of the greatest crimes is probably that the sign-up list behind me is so short, and there's, only 2 rooms for people to go into. So something that I think a lot of people who come to the conference could have a lot of fun with, and look forward to seeing how it hopefully continues to expand throughout the years.
Another popular event at IDWeek is the Idea Incubator. The competition encourages innovators and early-stage ventures to apply for funding for original inventions and ideas to improve ID care.
We recruit finalists from the field of ID and beyond, and they're really global finalists who have a solution to an infectious diseases challenge.
My idea is actually a portable HIV drug resistance test.
Our founder, who's a marine and medical microbiologist, hypothesized that there were chemicals in the ocean that were inhibiting the attachment of bad bacteria to surfaces.
So our idea is a low barrier personalized intervention to support the outpatient delivery of care for people with both HIV and opioid use disorder.
HIV drug resistance is very technical and expensive. And in resource-limited settings like the Philippines, there's really only 2 labs that serve 110 million people. In other parts of the world, especially in Africa and poorer areas of Asia, there is no drug resistance testing, but we know there's HIV drug resistance.
I'm really excited to be in such great company, and it's such a diverse set of ideas. I think that's the beauty of being an infectious disease physician who's interested in research. You learn so much from people who are conducting research in really a lot of different fields, and so it's been really exciting to catch up on their ideas and really learn from the process with them.
So it's very exciting for us to get recognized for something that is very relevant to our part of the world, but at the same time it can have global implications as well.
The judges are looking for solutions that will have impact on the community, the society. They're looking for scalability, they're looking for effectiveness, and marketability. We really want to find solutions to challenges in the field of infectious diseases, and so those are the things that judges are looking for.
What I would tell innovators of infectious disease is buckle up. It is a very long trip. You need to find supporters along the way, and this is possible through associations and partnerships and grants and so forth.
Next time on IDWeek TV, we'll be looking at respiratory viruses, transplants, and supporting women in ID. We'll see you tomorrow.